Good morning, everyone. Good morning, whoever that was. Hi. Are we ready to get started? Are we waiting for other people to come in slowly? I think it's okay to do both. Well, my name is Ryan Mueller, Colorado State Opioid Treatment Authority and Associate Director of Controlled Substance Licensing at the Behavioral Health Administration. And we are here today to talk about opioids, particularly their relationship with opioid use disorder, and we're going to talk about treatment for this disorder by way of medications, also known as MOUD, or MAT, medication-assisted treatment. Part of my role at the state is to regulate methadone clinics. That's one form of medication treatment for this disorder. Part of my role is to inform on state policy around treatment access. I am one of many experts in this work across the state, in this conference, and in this room. If you've been alive for the last 15 years, unfortunately, we are all a little bit wiser about opioids and opioid use disorder in this epidemic. So I know we're not starting from scratch. The goal of today's discussion is hopefully for all of us to walk out of this room with just a little bit more knowledge on this subject so we can go off and have our lives better informed and our communities better informed. Is that fair? Okay, y'all know me, if you do, if you don't. I'm a talker, but I love to have a conversation. So please raise your hand, ask questions during this. If you feel like there's some spot we're not quite getting to the bottom of, let's pause. Fair? Also, I have a laser pointer. I've never done this with a laser pointer before. I'm feeling pretty good about it. All right, so let's get going. I think of Dr. Rob Valek from the University of Colorado, who once said that we are pretty lucky to be alive in a time with antibiotics, with vaccines, and advanced pain support, advanced analgesics like opioids, for anyone who has experienced a serious medical injury or a surgery or cared for someone that you know in palliative care or beyond. You know the value of this medication. It makes us feel good. It takes away pain. It makes us feel euphoric. There are also some pretty significant challenges with opioids, some of which are listed up here and we're going to get into, but including respiratory failure and death. So it's a complicated story. Opioids can be divided into sort of three categories. Organic, which is derived from the poppy plant itself. I'm going to use my laser pointer up here. And you score the seed pod, and essentially the sap that protrudes and dries and hardens, you scrape off that resin, and that's essentially opium. If you were to boil this down in a crude way of saying with alcohol and water, that's sort of creating morphine. Don't get any ideas. Semi-synthetic opioids are when you take that organic compound and add to it a further chemical process. That's here in the middle. In that class, you have drugs like hydrocodone, oxycodone, even heroin. If you create an opioid compound completely devoid of any of these organic materials, you have a class of opioids that include fentanyl, methadone. I also included a little picture here of these little M30s. That is typically the drug that's sold on the street illicitly as fentanyl. It's pressed to look like a semi-synthetic oxycodone. It's probably important to note too that depending on, it doesn't really matter which class of opioid we're talking about, they all have the ability to have a super high potency and have the ability to be pretty dangerous. I showed my wife these slides before I came up here and said, what do you think? And she says, they look pretty good, but you're not gonna go through that history slide with them, are you? You're gonna put him to sleep. And I said, no, I would never do that. And here we are. I'm really sorry. The reason for that is I worked really hard on it, and the other reason is I just want to say a couple words on this, and that is that if we want to be better informed about where we're going, we have to know where we've been. And at no point in our history, all the way since back at the start of written history, have opioids not been around. There was a lot of double negatives. Opioids have always been around since that point forward. And at no point during that period of time have we not struggled with the balance between a couple of factors. One, the power of these drugs, the profit motive of those that control these drugs, the public's demand for these drugs, and governments in charge of protecting the interests of their city-states. And so this sort of balance happens all over the place, and the US is no different. We have our history too. For us, what really brought opioids into the spotlight was the convergence of three events. You have morphine, talked about that organic material, and the invention of the hypodermic needle. So imagine millions of years of evolution to bring us pain. Pain is what helps our central nervous system interact with the outside world safely. It enables us to live long enough, not be injured long enough so we can reproduce and pass on our genes. Well, suddenly now you have an ability to bypass that message that took millions of years to get to you through this injection. That's pretty powerful stuff. The other piece of this convergence is the Civil War that brought immense demand for analgesic support, but also opioids are super powerful anti-diarrheal and anti-cough medications. And back then in a war, you're more likely to deal with an infectious disease than a gunshot wound. So at this point, in the US, everyone knows now, medicine will never be the same. The way we look at pain and our expectations around pain will never be the same moving forward. Over the next 150 years, that goes by, and that same struggle continues. Pharmaceutical industrialists wanting to make bigger and badder products to make a profit, people that demand these products for all the reasons, and also government and regulators trying to figure out a way to balance all of that. And I'm on the regulation side now, and I have to say that at some points along that history, we didn't get it right either. Without correct information from science, without evidence-based understanding, without community input, you can make decisions trying to do better, trying to create a solution, and the solution ends up being more harmful than the problem itself. I'm happy to go into that a little bit deeper, but I promised you guys and my wife I'd move on. So, what is opioid use disorder, though? And I do think we should probably keep an open mind as we continue to have more and more data around this. But in current state, we see this as a chronic relapsing disease that involves complex biological, environmental, and developmental factors. And it is treatable, good news, by way of evidence-based medications and therapies. And the goal of opioid use disorder, really in treatment, is remission, just like cancer. This is really nice for like a 10,000-foot overview definition, right? But I still don't understand addiction. This should help everyone. The mesocorticolimbic dopamine reward pathway. Solved. Really, it's the brain's reward system. Let's just say that. I've never said that out loud before. You're the first people I've ever said that in front of, and thanks for being here with me. So I think the simplest way to describe the brain's reward circuitry, generally speaking, we all want to be alive. To be alive, you got to do things to keep you alive, whether that's eating, drinking, going to the bathroom, being around people. Because remember, most of our history as people, we've been hunter-gatherers, so to be amongst your tribe means you're more likely to stay alive. Reproducing. All of these behaviors that allow our species to carry on need to be reinforced. Well, just the fact that a good thing happens doesn't make it reinforceable. The brain actually has a chemical messaging system that ensures that happens. So in that system, that messenger, in particular here, is a chemical messenger known as a neurotransmitter. Dopamine is this chemical messenger, the feel-good neuromessenger. And it has to interact with different parts of the brain to get us to this reinforcement of behavior. So in one spot, a good thing happens, great. But you have to attach a good feeling to that thing, okay? But that's not enough. You have to remember that good feeling and that good thing. So memory has to be impacted. And lastly, you have to impact the portion of the brain that controls judgment, decision-making, and learning, so you can make behaviors more likely to get you to that reward again. Fair enough? Well, this is a pretty good system for us until you introduce to it a Frankenstein drug like methamphetamine, fentanyl, and heroin, and they totally hijack the reward system. Imagine you are like, going back to hunter-gatherer, you got your fur on in your cave and you're like looking for berries and you find a boysenberry or something, I don't know, and you eat it. Well, that berry might score like a 2 on some ever reward scale, encouraging you to go after berries again. Piece of chocolate cake might score a 100 on that scale, and fentanyl, methamphetamine, is 10,000. So it truly does hijack this system, and all of a sudden, all those behaviors that are meant to be rewarded to keep you alive pale in comparison to the reaction to that rewarding drug. And we say a reward system, and it sounds all nice and fuzzy. And oh, actually, I wanted to show you this first. Here's sort of like a real demonstration of neurotransmission. Yes, between neurons, right there in that synaptic cleft, I'll use my little pointer. And right here is a real, like, live demonstration of neurotransmission in the brain. So I'm not just making it up. It's a real thing. But we call this a reward system, and it feels like, oh, that's great, good feelings happen. However, remember, this system is built to keep us alive, so it is going to punish you if you do not do those behaviors to keep yourself alive, which it now thinks is using fentanyl, which it now thinks is using methamphetamine. So that is definitely part of the withdrawal cycle, and if anyone is dealing with an opioid use disorder, if they're not using, if they're not intoxicated, they're spending the rest of that time preoccupied with using again. All right, so this is a disorder. We diagnose it. I wanted to walk with you all through how do we diagnose this disorder? Okay, it is a complex interplay of the medical and the behavioral. So up here in this left corner, do you use more drugs than you have to? Sorry, let me say that again. Do you use more than you used to in order to achieve the same impact? If you stop using, do you go into withdrawal? Do you have to take more than you planned? Can you not stop even if you wanted to? Kind of over here now, do you skip out on obligations because of the use of these drugs? Do you put yourself in harm's way, psychologically, behaviorally? Do you ruin relationships? Do you use, despite risk of death itself? You start checking off these boxes. And if you get to 4 or 5 symptoms, that's a moderate opioid use disorder. If you get to 6 or more, you're looking at a severe opioid use disorder. And most people that use fentanyl on a daily basis are well past 6 or more into severe. So what are my chances of acquiring this disorder? That's a really complicated question. We are not born with everything that we need, like a little baby deer. We are people. We have to interact with our outside world. We have to learn, and that makes us who we are. So it is a complex interplay of genetics and environment. Certainly, exposure to these drugs in and of itself is a risk factor, particularly at a younger age. Exposure to behaviors that encourage drug use, super risk factor. Most people that are dealing with opioid use disorder, I think you heard some speakers earlier today that talked about use early on or witnessed use early on, and that is a direct indicator of acquiring opioid use disorder. But also, we know now through evidence that exposure to trauma, unmitigated mental health conditions, these are also risk factors. Opioids are great at killing physical pain, but they're also exceptional at temporarily blocking psychological pain. So people that have a need to deal with these things that have not found other coping strategies to do so, oftentimes turn to drug use, including opioids. Social determinants of health, I'm not going to spend a whole lot of time on this because we're talking about the individual, but from a macro perspective, it's important to know that communities that have more economic stability, running water, good housing, access to food, healthcare, education, strong social fabric, and hope for the future are less likely to experience preventable disease like addiction. And flip that around, communities that do not have these structures in place are more likely to experience them, including addiction. And good news, we've got some treatment options. We're going to walk through it. So do you remember the mesocortical limbic dopamine reward pathway? Okay. Oops, hold on. This is part of it. The extended amygdala. That is the portion of the brain responsible for our feelings, for our emotions. And it houses the most primal emotion of all, fear. And fear is a big part of the withdrawal experience for someone. And what we know about people who are going through withdrawal, it's not just fear of withdrawal, but it is fear of death itself. Remember, this system is intended to keep you alive. And if you don't do these things, you will feel that feeling. And so people spend a lot of their time fleeing from that experience. And it helps us understand a little bit better why people do what they do to themselves and to those around them, despite the character that they are that does not inform that kind of behavior. And it also helps us understand why the medications are so helpful. 2 out of 3 of the medications approved by the FDA, methadone and buprenorphine, immediately address physiological withdrawal. And I know that what I've heard in the past, and I still hear today, is you're just replacing one addiction for another, which is not true. We're going to get into that in a little bit. But I will cede the point that there is replacement going on. I want to turn your attention down here to this table. You probably can't even read that. I don't know why I put it on this slide. I think so you would take me seriously. But what is true is that opioids burn out of our system pretty quickly, right? If anyone in this room has had a major surgery and has had post-operative pain management, do you know what it feels like to miss that regimen of medication afterwards? I certainly do. I've seen some head nods. Okay, so that tells you it goes away pretty quick. And in a cruel twist of fate, fentanyl even faster. We've heard that that drug can burn off within the hour. This also helps us understand why people use, 20 plus times a day, 100 pills or more a day. Are they experiencing high and euphoria while using? Yes, much of the time, but also they're simply just trying to get away from withdrawal all day long. Exhausting. Methadone and buprenorphine, on the other hand, they are both opioids, but they last a lot longer in our bodies, particularly for the purpose of managing withdrawal symptoms. You take those medications once a day. So when we talk about replacement, we are replacing a couple of things. We're replacing illicit substance use, so drugs of unknown origin with unknown potency. Typically, cartels don't have ingredient labels on their drugs they sell. We're replacing the behavior of use itself, so whether that be syringe or smoking or otherwise, and all the infectious disease risk that brings, all the overdose risk it brings with drug use, all the time spent being high, getting the drug, also all the time spent acquiring those drugs through financial means, and all the behavior associated with that gets replaced when someone finds their way into treatment. Now, is it black and white like that? No, it's not perfect, but that's generally the concept. All right, so we're going to walk through a couple of these medications. Now, is this helpful? Is this where you all want to go with this conversation? Are there questions that come up already? Okay, I've answered it all. Feeling good. Methadone. We talked about this already a little bit. It is a oral medication. You take it once a day, either drinking it typically, which happens at a methadone clinic. It is in wafer form as well. It's also prescribed for pain management in a totally different setting, and we're not going there today. But this medication is super powerful at managing that physical withdrawal. It is an opioid itself that lasts a super long time. So replacing behaviors, reducing risks, and what's also important about this drug is also part of its challenge. You are required to take this drug at a methadone clinic. Typically, there are some exceptions to that rule, but by and large, if you're getting methadone, you're going to a methadone clinic. But what those clinics also offer is substance use treatment. And what we know now is while these medications are very effective at stabilizing someone's physical state, it doesn't solve the underlying issues that sometimes brought a person to that addiction in the first place. That is what treatment is for. This medication is more affordable, generally speaking, and it can manage co-occurring pain. Some of the challenges, it's really stigmatized. When's the last time you heard a politician drop the M word? Not really often at all. So if politicians aren't talking about methadone, then they're not going to be talking about funding methadone. They're not going to be talking about increasing access to methadone care. And it's limited. So it's in big cities, it's in some more populated suburban areas, and it's rare to be in rural or frontier communities, with some pretty cool exceptions, and we'll talk about that later. It can be, it's heavily regulated. There are medical side effects to methadone, no doubt, and it can be misused and can be dangerous when it's misused. All right, let's go on to buprenorphine. Methadone, on the one side, is a full-blown opioid agonist. So again, a lot of withdrawal management relief potential. Buprenorphine also has potential for withdrawal relief because it is a partial opioid agonist, but it does have a ceiling effect. It can't go above a certain amount. And for some people that works, and some people it does not work. Buprenorphine, it comes in a couple of different forms. There is a pill form, sublingual tablet, which means you put it under your tongue and it dissolves. Same with a strip. You know those little Listerine strips? Y'all remember those? Do they sell those anymore? I don't know. Okay, different generation. So that's a daily use medication. They also now produce a subcutaneous monthly injectable, injected into the fat layer under the skin, and that medication lasts for that amount of time. You're experiencing withdrawal relief. You're experiencing craving relief. What's also really cool about this medication is it can be combined with another drug called naloxone, also known as Narcan, the opioid overdose reversal drug. And so you have craving relief, you have withdrawal relief, and you have protection from other medications coming on board. Also, it's less regulated, so it's more popular, it's a little bit sexier of a concept, so you see a lot more prescribers and other facilities willing to go there and prescribe. Some of the challenges are it can be expensive, this drug, especially the injection, and it does have a limited withdrawal relief. So some people, anecdotally, providers or patients report, it doesn't quite get them where they have to go to get off of the withdrawal side of things. Also, it can be misused just like methadone, although less harmful when it is. And I think I already said this, but you can find this medication in pretty much any care setting, primary care, all the way up to inpatient residential care. Vivitrol. So naltrexone is this medication. It's the third and final FDA-approved medication to treat opioid use disorder. It acts very similarly to naloxone, actually. It blocks opioid receptors' ability to take in more opioids, and it's an injectable, an intramuscular monthly injectable. So during that month's time, you're really not able to experience the effects of other opioids. So there is a misuse reducing capacity. There is a craving reduction capacity to this medication. Also, there's a lot less stigma. Those folks that say, you're just replacing one addiction for another, one opioid for another. Well, Vivitrol doesn't fall into this category, so it is celebrated in certain communities. Some of the challenges are, again, this is an expensive drug too, and it does not manage withdrawal symptoms. So for folks that need that element in order to be successful in recovery, they won't find it in this medication. All right, we're gonna keep on moving, unless y'all have questions. Please. Sort of, kind of, and I'll do it again. So antagonist, like Vivitrol, like naloxone, block opioids from coming into the body, from us to feel their effects. An agonist is sort of like another opioid that says, hey, I'm gonna do the same thing, right? Like methadone is an opioid, it does the same thing as other opioids, but when prescribed appropriately, it's not going to provide you a euphoria like other medication opioids that you might be taking. Did that help answer the question? Yeah, thanks for the question. All right, so myths, I'm not gonna go through all this, but I do wanna focus on the top one, and that is, oh, you're just replacing one addiction for another, giving medication for this disorder. And here's why I would disagree with that, and many others would too. When prescribed appropriately, thank you for that segue, I feel like I have a plant in the audience. We are not providing euphoria. People are not high. From my own personal experience working in methadone clinics, what we saw from people that would come in for care is once their pain and once their physical withdrawal was ameliorated in treatments and they saw that relief, they would become pretty tearful, unhappy, anxious, sad, depressed. Couldn't figure out why there was so much dysphoria associated with this treatment until we figured out that they are no longer getting that pause button on their emotional trauma. They no longer have euphoria to block all of the things that that drug was also doing for them. So now is the real time for treatment to start for these individuals. So that's one answer. But the other is, once they replaced all those other behaviors and they're working through their symptoms, they're going to counseling, they're working with peers, they're working the system, they are able to do other things. like reestablish their lives, get work, establish relationships again. And all that stuff that you start to check boxes on, go back to, I'm going to try to click back, I'm sorry. You start to uncheck these boxes. And suddenly a person moves out of severe, moves out of moderate into mild opioid use disorder or in remission. So objectively, they are no longer qualifying for having a severe or moderate opioid use disorder. All right. Yes, please.
I just wanted clarification. When it says that it's recommended for a minimum of 12 months, is that to slowly reduce the amount that they are taking in order to get them off of that as well? Or is it just a minimum?
Ooh, that's a really good question. So it is recommended for a 12-month, I think it was the National Institute for Drug Abuse recommended 12 months for maintenance. So to stay on the same amount, an amount that alleviates your physical withdrawal for that period of time. After which, everyone's individualized. So someone might be ready to wean down sooner. I've met with some people that said, you know what, I've been using for 25 years, I'm done, I'm taking this medication, and that's what I know I need. And what's really important is to emphasize that this is not a one-size-fits-all, and providers shouldn't look at it that way. You interview the person and figure out what they need most.
So I just kind of want to piggyback up what she said. As far as the 12-month period, explain to me why people are being weaned onto it instead of off of it in that sense.
So can I rephrase the question? Why would we put someone up to managing withdrawal levels and keep them on there for 12 months rather than try to help them come down?
People go from like the 4 milligrams, 8 milligrams, 16s. I never understood why they were getting higher and higher doses. So coming in here was perfect because I was like, well, I can find out for myself.
Right on. Well, oh gosh, another plant? Please feel free.
Hi, I'm Elise Tirhar. I'm the medical director for Community Medical Services. And what I've seen is we try not to start people on doses that are too high for them, for both Suboxone and for methadone. And so when we're putting people into treatment, we don't want to put somebody on a really high dose of methadone because it is so individualized. And so when we're starting people on treatment, we're going to usually start as low as we think will still work for them. And then as time goes, we're going to get them to a point where they feel comfortable. They're not having bad side effects from the medication. They're not having, significant cravings or withdrawal effects. And then we want them to feel good there and get their lives together. For the second part of your question, why are we not pulling people down? That's really an open question. Like I've talked to 2 patients this past week who are planning to taper. And so we want them to be successful. I would say everybody here wants people in recovery to be successful. And for some people, that means staying on the medication indefinitely, because when they're on the medication, they are living their lives and they're doing really well. And for other people, that's gonna look like tapering and then maybe coming back too. Did that answer your question? Yes. Okay.
Thank you. Thank you.
Does the limbic system regenerate its ability to produce dopamine? I know the external opioids reduce the body's ability to produce the dopamine. Does that return, and is it individualized for everybody?
Oh my gosh. Are we talking about neuroplasticity? I think I need the plant doctor again. So I would say this, that certainly the brain is a very powerful thing, and adaptation is the reason our species is so successful. And when we are not experiencing euphoria over time, absolutely we relearn, and those levels can come back down. But I think from the doctor's perspective, I think I might need to lean on a medical expert to say, what does that mean long-term when you're on methadone? But certainly we see people living very normal lives and not going into that space of euphoria and dealing with severe opioid use disorder. So does that answer your question? From the limbic system, yeah.
Regain your ability to experience joy?
Absolutely.
That opioids, external opioids, deprive you of the ability to experience joy from lifetime events because your body loses the ability to produce dopamine, or it it reduces the amount of dopamine it produces. Does that bounce back?
Yes.
So a great example of this would be alcohol use disorder to me, which is that when you have alcohol use disorder, the neurotransmitters that your brain produces naturally go down because alcohol is replacing that. And so that would be the best example I can give. But as people stop using and stop artificially replacing something that their body makes on its own, the body ramps that back up. Not for everything, but specifically when I talk about neurotransmitters. So your body keeps making dopamine, it keeps making endogenous opioids, and it ramps it down because it says, well, I guess you're giving it to me, and that feedback system changes. But when that feedback system says, well, I need more of that, your body ramps it back up.
Did you say therapy helps? What's that?
Should I take this?
Oh, yes, please. Can we write therapy helps on the wall somewhere in here? That's really the message of today.
Hi,
Hi.
I'm just kind of answering your question on the other side. I am a person in recovery, and I think once we address the underlying issues of why we're doing the drugs and go through the treatment and learn coping skills and all of this good stuff, I have experienced more joy and happiness and everything above, more in recovery than I ever have in my life.
Thank you so much. Thanks for being with us today. Okay, how are we doing on time? Are we doing all right? We're doing okay? Okay. So we're just going to keep on moving real quick here. Yeah, we got another question. Yeah, please. Got 15.
And if you're going to answer this question, just tell me to, screw off. But what are the infectious disease screening requirements to enter medication-assisted treatment?
Oh, I wasn't ready for that one. Well, so with regard to entering a methadone clinic,
With regards to entering medication-assisted treatment, MOUD, it could be methadone, whatever, yeah.
okay, thank you for that. So the question was, what are the infectious disease screening requirements in order to accessing medication? And that's sort of, it depends. So when it comes to Vivitrol or buprenorphine, there's not a singular model of regulation that are over these medications, so it depends on your provider. You might go to some facility and they say, well, these are our requirements. You might go to your primary care provider and they'll say, well, we're just gonna prescribe. And now methadone clinics are a little different. They're licensed by the state, they're licensed by the feds, and there are infectious disease screening requirements that are fairly clearly laid out for them. And part of that is infectious diseases, STIs are on that list, certainly looking at hepatitis, and just trying to screen for any other potential issues that could interfere with the ability to receive the medication, but also recognizing that a lot of folks that come into service also don't have primary care. And so you might be catching some of these disease states for the first time for that individual. I remember when I started this work, hepatitis C wasn't curable. Do you all remember that? Yeah. Scary times. Those conversations were a lot harder with people when you had to disclose their status, their diagnosis. All right, so I'm still going here. Moralism and abstinence and addiction. What I just talked about, all those medications, are all driven by science and evidence. And now, I'm not knocking us as people for our past way of doing things, but in the lack of that evidence, we had to figure out, again, how do we control these medications? How do we control harm to our communities? And the best we did a while ago was the morality argument that, in fact, it's not a physical problem with your body at all. And it's a psychological one. It's a spiritual one. And so if we just apply shame, if we just tell people to try harder, you know what? You can work your way out of this addiction, no problem. The abstinence model sort of goes in that hand in hand to say, just stop using. Even though the evidence tells us if you have a moderate to severe opioid use disorder, you are less likely to experience recovery without medication. The criminalization side of this, I want to be really careful and say, that's a complex subject. And you could spend a semester, you can spend a career studying criminology. And so the purpose of it to be said here is really from an epidemiological one, in that for a long time, we sort of punted the problem of addiction to criminal justice in our nation. We said, you guys figure it out. And that was really unfair to them and unfair to people in recovery or not in recovery. And what we found was between all, laser pointer, all three of these considerations, philosophies and practical applications of practice, we did not decrease relapse, we did not decrease opioid use disorder, and we did not decrease risk of overdose. Fair? In fact, I'm gonna go off on a little tangent here. On the morality argument, if you're curious to learn about some of the origins in more modern day, England in the 1850s, 1860s, they were in the depths of the opium trade wars with China. And some of the backlash of that experience kind of landed into the more religious side of things where they said, you know what, this is a spiritual problem. But before that, a lot of people recognized the powerful and dangerous aspects of opium itself. So kind of an interesting shift in the public's perception. They had it right the whole time. Okay. Also, I'll just add that when pharmaceutical companies, during the most recent pandemic, needed to find a way to get pills out to the public for profit, they kind of relied on that argument themselves. And they said, you know what? It's not the pill, it's the person. So by us giving out more pills will not increase addiction in our community. And we know where that went. I'm not going to read through all this. Ooh, thank you for that. 10 minutes left. Oh my God. Okay. We got a lot of material. I'm going to have to triage here. This is really just to say a couple of things. That one, evidence tells us if you're on medications for opioid use disorder through your moderate to severe opioid use disorder, you are more likely to experience recovery, you are less likely to use illicit substances, and you are less likely to die from an overdose throughout the course of your disease. Now, I'm going to sort of lightning round through some of this just to give you all a little bit of a perspective in our states if you want it. We think that there are around 120,000 people in Colorado dealing with an opioid use disorder at any given time. About 41,000 of them are in treatment. A quarter of that is methadone. About 10,000. Buprenorphine is the other 30,000, a little smidge of Vivitrol there. But why are folks mostly not enrolled in treatments? That's very complicated. We're complicated people. Access is certainly one of those challenges, and this is really just to say that methadone clinics in general, remember, government's trying to figure out a way to limit harm to their communities from opioids. Methadone's an opioid. So the concept of an opioid methadone clinic was built on restricted access. That worked for some people, but it doesn't work for all. And what we found was, you know what? One, we're having a retention issue in methadone programs, but why is that? And the data has sort of borne this out, that transportation, low methadone dose, missed doses, and incarceration are the top 4 reasons that people don't typically do super well in treatment. But what do all 4 of those have in common? Anyone have a guess? Yes, that's a good answer. It starts with a W. Withdrawal. If you miss your medication, you're more likely to experience withdrawal. If you're in withdrawal, you're more likely to relapse and you're more likely to drop out of treatment services. So if you want to address people dropping out, you're going to have to figure that out. And fortunately, we've had that catalyst in COVID. Nothing really good came out of COVID except for this, I'm pretty sure. This is like one of the top things. And that was our ability to rethink methadone care in general. It used to be that people would have to come and get a dose every single day at a clinic for the most part. That's 50 years. And now suddenly we're able to allow people to self-administer methadone at home. And what we found from this, both at the federal level and the state level, because we both participated in this 5-year social experiment essentially, is that methadone retention went up during this time, census went up during this time, treatment outcomes improved, and also equally importantly, methadone-related overdose deaths did not go up. So during this period of time, this is not the only factor that has changed the way we have medicine happening right now in our state, but we've seen an increase in methadone clinics across 30% more counties. They've doubled in numbers. And now finally we're getting more care into our carceral setting. This is just to show you that universities are starting to study the effects of these changes, of allowing people more access to their medication. The University of Colorado just published this, studying their 3 methadone clinics. And just the long and short of it is that they found meaningful improvement to patient retention and engagement and satisfaction in service. Just some more data to throw at you. In the last, 5 or 6 years, we have seen buprenorphine care and methadone care double across our state. There's a whole lot of reasons for that. I cannot emphasize enough that need is probably the biggest reason we've seen an increase. So yeah, yay for us for doing regulatory changes, and yay for the providers for kicking butt and opening new services, but there's a lot of need in this community, and that's driving some of the enrollments. In the carceral settings, now as a state opioid, thank you, 5 minutes left. Okay, I can do this. In my role, every state has this role. Every territory in the US has this role. And I get to talk to them, and I get to learn about how other states do their business. And unfortunately, not every state is super effective at getting treatment into their carceral systems. They're just not. Some don't want to do it, some don't support it, some of the jails don't support it, some of the providers don't support it. We are very fortunate to live in a state that does. And I'm here to say that every one of our 55 municipal jails provides some form of MOUD and receive methadone deliveries from methadone clinics, which is pretty darn cool. Yes, most carceral MOUD ever in current state. All right, I thought I'd get a clap, maybe not. Thank you, thank you. I mean, the reason that's so important, and not to harp on it, but if you go into a jail and you are experiencing an opioid use disorder, untreated without medication, you are 129 times more likely to die of overdose than if you didn't go to jail at all. And in fact, and this is a pretty disturbing statistic, the #1 cause of death upon exiting a carceral setting of any kind in that month period is drug overdose. So if you really want to take the conversation seriously about addressing death from opioid use disorder and overdose, you've got to lean in energy to the carceral system. That's where the medication has to go. So we do see this. You hear about overdose deaths declining, fentanyl deaths declining, and that's great news. There's some reasons for this. There have been some successful efforts at an international stage by the US to put pressure on those who produce those precursor chemicals that help create a super strong version of fentanyl. And so cartels are struggling to keep batches super potent. That's one reason. And by the way, where did I get these bullets from? Asking providers in our state, asking providers nationwide, asking regulators. This is kind of like an amalgamation of all their opinions. So that's one factor. Also, more people are in treatment. You all saw that slide before that we've doubled our census, which is really great. Naloxone prevalence. You heard Attorney General Weiser talking about naloxone distribution being a major contributing factor to reducing overdose deaths. Along with that, education, huge. And I cannot emphasize enough too that non-fatal overdoses are still extremely high and very dangerous and very impactful to our communities, and so we cannot take our eye off the ball. Oh, look at this. This is kind of a weird, well, focus on here, laser pointer, over here. Cartels are still going to want to make a profit, and if they can't sell a fentanyl that's strong enough for you, well, they're going to put more crap into that batch that makes it strong. So we're going to start to see, and we already see on the East Coast, nitazines, which is a super dangerous class of opioid that was actually never legalized for use in the United States. But they're able to get their hands on those ingredients a lot easier, so they're starting to put it into fentanyl batches. Xylazine is an animal tranquilizer, actually, and we're starting to see that mixed into batches, and that also can increase your overdose potential and cause all kinds of horrible things, like skin lesions and necrosis. But what's worse is xylazine, being a tranquilizer, being a non-opioid, it doesn't respond to Narcan. So we're pretty worried about this. We are on alert. I know our OTPs and other drug treatment providers are doing great with screening and education and all the things that come with that. I don't know what happened with the formatting here, but Kratom is something else to talk about. Do y'all know what Kratom is? Have you heard about it? Getting some head nods. That's good news. So it's essentially a gas station heroin, right? It can be sold really anywhere in the US. It's not an opioid. But what it does do at high doses is mimic the effects of opioids and also mimic the withdrawal effects of opioids. So what we see is unfortunate is for folks that are dealing with kratom withdrawal, sometimes crossing over into much more dangerous opioids to seek relief. But make no mistake about it, it is access to treatment, it's access to medications and naloxone that are driving our overdose deaths downward. So please keep up the fight. I'm just gonna put these takeaways up and answer any questions if you all have them. You've been lovely, thank you for your time. We got one. We got two. Doc, you're not going anywhere, are you? Okay.
Hi there. I was just going back to the chart that you have with the opioid, the history of, all the drugs, and it's 3,000 years that
Yeah.
opioid's been around.
Yeah.
Opium. And I'm just wondering why do you think that we're still trying to make something illegal that's been part of different cultures for thousands of years? And why aren't we seeing a discussion about legalization? Hardly at all. And regulation.
Oh, what a great question. Okay, we're not done. It sounds like he's in the room.
Also like to ask that all members of the Colorado Opioid Abatement Council please go to the front near the banners to join us for a photo. So please, all members of the Colorado Opioid Abatement Council, please head to the front ahead of the banners near the front door for a photo. Thank you so much.
Okay, I'm ready. I'm ready to answer this question. It's a great question. Part of the answer is because we don't know any better, honestly. And remember those competing interests I talked about, the power of the drugs, the profit motive of those in control of those supplies, and different governments of these city-states that have to sort of have their own take on what they believe is right. Sometimes that's going to go to the moral side. Sometimes it's going to go to the legal side. Sometimes it's going to go to evidence-based, right? You see different countries that apply different perspectives. And there's no universal, global anything that drives that. So you're going to, hopefully we win the day. Hopefully that people lean into science. That's why I'm here. That's why you're here. But I think we are headed in the right direction. Yeah. Is that a decent enough answer? Okay. Okay.
I will be really quick. I actually come from a state that falls in one of those that do not really have medication-assisted treatment in the jails, really statewide. And so I'm just wondering, what would you recommend as kind of a starting point for trying to get that going?
Ooh, that's a great question. Find your champion. So I would visit jails directly. I would talk to people in decision-making positions and ask about their experience, because chances are they see people suffer. And chances are they don't want to see people suffer. And maybe their perspective might help to inform. If you get them included in the conversation and at the table, they might be more willing to be your champion when you need them. Yeah.
Quick question.
Yeah.
All good? So on additional options, kind of piggybacking on the idea of decriminalization, as the soda, how do you feel about additional options like hydromorphone-assisted treatment, long-acting morphine that they have in these other countries? Because sometimes when buprenorphine doesn't work for someone, sometimes those other medications will.
Oh, that's a great question. I think we should always keep searching for better options. And so when the evidence presents itself in a meaningful way, I think that's where we need to go. Do I know a lot about this drug and its effects and how that would go for someone? I don't yet. So I'd be interested to learn. Yeah.
So I've myself been on Suboxone for 6 years. It has been very, very helpful for me in my recovery, but I work in a large sober living, and I finally championed us to allow Suboxone, but I'm still struggling with methadone. The stigma there is bigger. Do you think that methadone, I mean, I've seen that the research shows that that's more helpful for fentanyl than Suboxone, so is that like a good argument to bring back for allowing methadone?
Yes, I mean, what type of cancer treatment do you need to treat your cancer? I don't think that a residential facility should get to decide that. And same with this medication. Some methadone works better for, and some buprenorphine works better for. But I don't think they should be able to discriminate what drugs come in. And in fact, I'm gonna, just a BHA plug, for any agency that's licensed with the BHA, you are required to provide access to all forms of MOUD. So if you're a licensed provider, Medicaid also has this requirement. So if they hear that you're saying no to methadone, that's something we would like to learn about. Yeah, because I totally agree with you. He's back. Are we good? Thank you all. Go get some lunch.